So, welcome to the show. I'm joined by my guest, Dr. Perry Maynard, out in Denver, Colorado, of Integrated Health Systems. Thanks for joining me today, Dr. Maynard.
Yep, thank you guys so much for having me. I'm excited to chat today.
Yeah. So, you really want to talk about dizziness and vertigo today, is that right?
Yeah, it's definitely, I'd say, probably the biggest population I see in my practice is patients with dizziness, whether it be from head injuries or inner ear disorders. So it's a topic that I feel pretty comfortable on, and I enjoy seeing those types of patients.
Perfect. I love this topic, so I think we're going to have a great conversation. I'm excited for what you have to say.
Cool.
So before we get started, I usually like to ask people what really led them to their particular field, what led you to your particular love of treating patients with vestibular and dizzy disorders.
Yeah, so I originally, so for those who don't know, I am a chiropractic neurologist, so my degree's in chiropractic. So I actually played college football. Mm-hmm. And while I was in school, I was pre-med and I had a minor in neuroscience. So I was always really fascinated by the brain. Mm-hmm. And then I decided I wanted to go to chiro school, and I was like, well, I'll probably never use this. I'm just going to do like sports medicine, adjust people, and the brain is interesting, but I'll probably never use it. And then I was at the NFL Combine in like 2008, and I actually heard Dr. Carrick speak. And I was like, wow, this seems really cool. And this guy's a chiropractor. Mm-hmm. And so maybe I can use this neuroscience background. So when I got into school, I got involved in the Carrick Institute, like try one. And so I started for my diplomate at the very beginning and was doing a lot of like sports medicine, neuro, and I was kind of torn between the two, right? Because the neuro takes a lot of attention. Mm-hmm. And then I ended up working with Dr. Glenn Zielinski in Portland, which is a great neuro clinic for a little bit, and just got exposed to so many head injuries and so many different neurological disorders. I just kind of fell in love with that line of work. So that's kind of how I got into that. And then honestly, one of the biggest influencers from the standpoint of dizziness is actually Dr. Traster, who also kind of works up at your clinic recently.
Yep.
And there's something about dizziness to where it makes sense to me, mm-hmm. right? Inner ear and how we perceive gravity and its influences on perception and its influences on so many other things I just find super fascinating. So I feel like it's easier for me to study and easier for me to apply. And I tend to have just had more patient successes in that arena. So I think it's easy clinically to lean towards something that you get better results with, mm-hmm. and you kind of shy away from the things that you're not so great at. So yeah.
Absolutely. Well, sounds like we got the right person for this topic then. So you had mentioned that the vestibular system detects gravity, right? Mm-hmm. So run us through that a little bit, maybe how the vestibular system works and how it could go wrong.
Definitely. And this is what I kind of tell patients a lot of times, and anyone who's dizzy, disoriented, whatever it may be, is I always have them think of their body in kind of maps, right? So I always talk about we have a head map, right? So we have to know where's our head relative to the world around us, mm-hmm. right? And that's largely your inner ear, right? Because your inner ear is the only thing that's really embedded in your skull. And right, so you have all these different hair sensors, and as gravity pushes down, depending the position of these sensors, right, it moves hair cells in different directions, and it says, my head's left, my head's right, it's up, it's down, right? Mm-hmm. And so that's your head map, right? But it doesn't stop with your inner ear, right? Because now that you know where you are, right, now you have to know where's the world in reference to you, right? So if I want to grab this phone in front of me, I first need to know where I'm starting, and then my vision can have an appropriate idea of where I am in the world, mm-hmm. so that then I can judge where that phone is, and then I can reach and grab it, right? But it doesn't even stop there in that I now need to know where is my neck, right? Because my neck now tells me, okay, my inner ear says my head's here. Okay, here's my body relative to my head, so now I can interact. So we really try to link all three of those together, understanding the visual system, the inner ear, and the neck. Mm-hmm. But I do agree with you that I think it all starts with the inner ear, because you can't get away from gravity. Mm-hmm. When you sleep, gravity's there. When you're awake, gravity's there. Unless you are under the ocean or under the water or in space, you really can't get away from it, right? So that inner ear is something that's always being stimulated to let you know where your head is in the world.
Yeah. Yeah, and I like that you brought up the three components of, the three systems that really tell us where we are in space, that we have to have all working in synchrony.
Mm-hmm.
So how would I know as a patient, whether my dizziness is coming from my inner ear or my neck or my visual system?
Definitely. So I think first is definitely getting assessed or worked up from someone who understands those things, right? Because it can be hard as a patient to really differentiate those because they can seem so similar, right? Neck dizziness versus inner ear dizziness can almost present exactly the same. So at least, we have different ways where we can kind of tease those different things out, right? So I think finding a really well-educated physician who's trained in that arena to really assess you and be able to dial those things in. But the big things we kind of look at is, so we'll look at a lot of, we'll use what's called like V&G, so goggles, where you can go into the darkness and look at different inner ear or different eye and inner ear reflexes. So that mixed with balance, I think can tell you a ton about the inner ear, right? Because balance is really, really cool because it allows you to manipulate different sensory systems, right? So if I have someone on a hard surface and I take their eyes away, now I'm seeing how well can they rely on their inner ear and their feet. And then maybe I put them on foam, right? So it's all about almost trying to decompensate someone and see if you can bring it out, right? So can you do something to the inner ear? Can you take away the visual system? Can you manipulate or do something to the neck? And all of a sudden see, okay, that seems to be the weak link. Because I think it's all about what system's broken, what system is the patient compensating with that may be causing symptoms, and saying, can we either fix that system or can we give them a better compensation strategy to make them feel a little bit better, right? So there's a lot of cool diagnostic tools that can really help you triangulate inner ear versus vision versus neck.
Yeah, absolutely. And like you were saying, you want to eliminate with the balance testing each variable so you can really tease out and know exactly which component is causing the dizziness, and that's going to make your treatment strategy that much more effective.
Totally. And what I've come to realize, and once again, I've learned a lot of this from a lot of the colleagues at your office and things like that, when you're doing things right with the inner ear, when you really tease them out appropriately, you can make changes like that. Rarely is it something that takes a long time. If you can really tease out what system's affected, and you can make an appropriate intervention, you can change people's dizziness, within seconds and within minutes, which I think is really cool about that system as well.
Yeah. So, yeah, I agree. So what are some of the forms of dizziness? What are some of the, maybe we can get into some of the pathologies and maybe how they would present and how a patient might recognize their specific form of dizziness, maybe some common examples that you see in your clinic. Yeah,
definitely. So I always break it down with patients kind of in a few different ways. Is there can always be either damage to the actual inner ear itself, right? So I always say peripheral, or I use the analogy of the peripheral inner ear is the bike, right? And then certain parts of your brain are the bike shop, right? So you can break the bike and have an intact bike shop and bring it back to that shop and get it fixed, right? So there can be damage to the actual inner ear. So I say most commonly we see is one is called BPPV, or benign paroxysmal positional vertigo, right? And that's honestly, you see that more often than not with a lot of concussions because of the blow to the head can break debris loose into the inner ear. So you can get kind of gunk that floats around in the canals. And then we see a lot of Meniere's disease. And Meniere's there's a lot of debate if it's an autoimmune or inflammatory condition, right? But it's a condition where you're attacking your inner ear itself, right? I'd say those are some of the most common actual peripheral inner ear disorders we tend to see. And then, like you're aware of with concussions, is sometimes the inner ear is disrupted. Other times you damage the central areas of the brain that have to do with compensating and kind of tweaking and manipulating that inner ear. Yeah. So I'd say we see a good mixture of actual inner ear damage versus just concussions that affect the central structures that kind of communicate and keep the inner ear in check.
Great. So based on your testing then, how would you then tease out, a peripheral versus a central maybe?
Oh,
Or
right. Yeah, that's a great question. So, like I said, balance is kind of like a snapshot, but it doesn't really let you know peripheral versus central.
Mhm.
So there's some good bedside tests that I really like. One is called it's called a head impulse test, right? So it's a test where you're staring at a nose or a target, and your heads move slowly and then quick impulses. And when you look at a lot of the research, it's a lot more sensitive for individuals who have peripheral deficits, right? So there's a lot of different testing, and when they kind of all line up together, you can start to tease those things out. So a lot of good bedside testing mixed with B&G testing. So by putting someone in the dark, you can see different types of eye and inner ear reflexes, right? So what's called nystagmus, right? So nystagmus is where your eyes will drift in a direction slowly and then beat down quickly, or they may drift to one side and then beat back quickly. Depending on that type of nystagmus, that can differentiate peripheral versus central a lot of times. So depending on if there's torsion with it, if it fatigues out. The other big thing is, right, so V&G testing, but with every patient, we're always doing positional testing, right? So this is really how we rule out things like BPPV, right? So you can take a person, put them in the dark, and then you can put their head in different positions and move their head in different positions. And depending on how you see their eyes move, you can say, ooh, they must have some sort of gunk in their inner ear, so they fit more into this BPPV category. Or maybe that's negative, but they have a ton of clinical findings that show peripheral vestibular loss, right? And they have hearing loss, they may have ringing in their ears, all these other things that come a little bit more with actual damage to the inner ear versus all of the peripheral tests look normal, but they got these really funky nystagmus in the dark, right? So when you take their vision away, their eyes start moving all over the place. You can start to say the brain's not doing a good job interpreting what the inner ear is saying. So pretty much taking bedside testing mixed with B&G testing, mixed with positional testing that you'd see in a lot of traditional vestibular rehab, really gives you a big picture saying, hey, they have a lot of peripheral findings and not many central findings. Okay, how can we now categorize what peripheral deficit it may be, or saying, hey, the peripheral system looks perfectly fine, this must be more central, it must be more brain. Now we really have to look at integration of the neck and the inner ear, or things like the cerebellum and stuff like that.
Right. And then, for example, once you find kind of the target area that is really causing this person's dizziness, what are some examples of some treatment approaches that set you apart, that you would use to intervene in these cases?
Definitely. So I'll give a kind of a cool example of a patient we had, because it's definitely not the norm. But a patient who had 2 years of persistent dizziness. She had a viral meningitis, and she'd kind of been everywhere. She couldn't shower by herself. She couldn't walk. She couldn't really do anything without help. So she came in, and we were kind of working her up, and she almost had like a Mulday debarkment syndrome type presentation where she'd be rocking, she'd be bobbing, she was feeling like she was moving. And what I'll usually do with patients is, as I'm going through a lot of the testing, we'll kind of challenge different systems, right? So I may, as I find a finding, see, can I fix it? And does that make a difference with this patient, right? So this patient had, her peripheral inner ear looked really pretty good. But what we found is that when we did optokinetics, so when I moved the red and white stripes across her face, it just would tangle, and she'd feel like she was rocking and moving. So I think in my head, okay, so this visual motion really bothers her. Is it actually a visual motion issue, or does she just not know where she is, so that now visual motion bothers her? So I simply just had her take her hands, wrap them around her neck, and then I re-exposed her to the optokinetics, and it totally normalized it. So I'm starting to think, okay, she doesn't know where her head is. Does it have to do more with the neck or something central inner ear, right? She was a patient where I was like, I'd have her walk down the hall and she couldn't walk by herself. Wrap her hands around her neck, she could walk down the hall no problem, right? So then we used some rock tape. So we did some rock tape on her neck, and within 1 day, her dizziness was down by like 80%.
Awesome.
She still couldn't handle cars or things like that. But then that's why in therapies, what we started to do is we would hook lasers up to her head and her trunk, and we did a ton to try to integrate her understanding of where her trunk was versus her head, right? And then once we did that, we started then exposing her to a lot of busy visual motion, but while working on the neck. So kind of an example where we really didn't touch the inner ear at all, but her brain had trouble interpreting what her neck was saying,
Mm-hmm.
right? And being able to tease that out with just kind of a little audit, you can say, okay, now I can make a therapy that's appropriate for her, and it has profound effects for her. So kind of a cool case where the neck was playing a little bit more of a role.
Yeah, and I love that. I love this field in that we're able to do those little audits, these challenges, and really make an immediate change. And it's, a pretty good indicator of what's going to be helpful for that patient. And
Yeah.
it really makes coming up with the treatment plan a little more effective, I think.
Yeah, I couldn't agree more, and that's where I see a lot of issues in traditional inner ear rehab. And then they just kind of give a blanket therapy,
Mm-hmm.
assuming that it will work because it's worked for other people, but really it doesn't work like that. You really have to tailor it, and I don't think I've ever given patient the same thing I've given someone else
Mm-hmm.
for the same reason and had to be effective. Everything's got to be very tailored for each person.
Right, and that's another question we can go into. You have your standard vestibular therapy. So you say that what we kind of do is much more specific, right?
Mhm.
Based on all the testing, based on the challenges, versus maybe something you might get more traditionally, maybe more cookie cutter. Would you say?
Yeah, I'd say so. I think most of traditional inner ear rehab thinks about the inner ear as just the inner ear,
Mm-hmm.
and I think they think that the rest of the brain's intact and it will kind of figure it out, right? That's why a lot of traditional inner ear rehab is habituation,
Mm-hmm.
right, or exposure therapy. So the idea of being like, hey, you get dizzy when you turn your head to the left. Well, just turn your head to the left and keep turning it, and
Mm-hmm.
eventually your brain will figure it out.
Right.
Versus we say, that doesn't make sense. They're just going to create a weird compensation. We got to figure out where's the mismatch that when they turn their head to the left, they're
Mm-hmm.
getting a sensory error. Versus I think traditional says, well, we don't really care about that. The brain's smart enough; it will kind of figure it out. So
Mm-hmm.
that's why I think a lot of the therapies are very similar. Stare at this dot, turn your head quickly, up and down, forward, backwards, and they say, hope the brain compensates for them. Versus we're saying, let's be a little bit more detailed and find why they can't do those things and then make a specific intervention.
Yeah. Yeah, and I'm glad you brought up the fact that the brain is able to make compensations, but the compensations aren't necessarily a good thing.
Yep.
So, what are some accompanying issues that you see with a lot of your dizzy patients that may be from compensations or maybe just as a result of them having chronic or acute dizziness?
Definitely. So it's kind of crazy because it runs the gamut. And I'm surprised every day in practice at the symptoms that resolve when you fix inner ear issues. But I'd say most commonly anxiety,
Mm-hmm.
emotional distress, a lot of times a lot of nausea, and what seems like GI issues, but
Mm-hmm.
really it's nausea, vomiting, diarrhea, a lot of these kind of autonomic things. See a lot of dysautonomia or things like POTS and orthostatic hypotension. So where
Mm-hmm.
people stand and they feel faint, they feel dizzy.
Yeah.
I'd say those are some of the most common. The other things I see a lot is fatigue,
Mm-hmm.
fatigue and like memory loss and brain fog, right? So a lot of these patients are saying, I just feel kind of foggy. I feel slow. My memory's off. I don't really know why I walked in this room. And a lot of people may say, hey, well, we got to work on memory exercises or something's wrong with your temporal lobe or your frontal lobe or whatever it may be.
Mm-hmm.
Well, really, a lot of times that fatigue is because they're just spending so much energy trying to compensate
Right.
for feeling so dizzy. Because I always tell patients, if your brain had to choose between one thing between knowing where maybe who your kids are and knowing where you are in space, your brain will always choose understanding where you are. And
Right.
it will forget work, memory, all these other things. And what's cool is a lot of times you fix those things, memory comes back, energy improves, anxiety decreases, and things like that. So
Mm-hmm.
it's pretty fascinating to see kind of the gamut of different symptoms that can come that seem unrelated.
Mm-hmm. And to backtrack a little bit to something you said earlier, you mentioned POTS and dysautonomia.
Mm-hmm.
So when you say dizziness, that could mean a lot of things, right?
Mm-hmm.
So a vestibular dizziness, a vertigo, that dizziness is going to look a lot different than like a POTS, a dysautonomia dizziness, or what someone might describe as dizziness. So can you kind of break down maybe the difference between those two and how people could maybe know if I have one or the other?
Yeah, definitely. So when you look at that, and you're totally correct, because they can look and sound similar, and the way people describe things sound similar. But when you look at POTS and orthostatic, right, they'll give you dizziness, they'll give you anxiety, all the similar symptoms. But the big thing is a history when it comes to dizziness is so important. So how someone describes their symptoms. Are you spinning? Are you floating? Are you bobbing? Do you feel like you're part of your body? Do you just feel lightheaded, right? So a lot of patients with more so dysautonomia are going to feel like they're fainting. They may or may not feel like they're spinning in some of these other symptoms, but a lot of times those are the patients where they say, I'm pretty good sitting. I'm even better lying down, but I don't do good when I'm against gravity. When I go from lying to standing, I feel crummy. When I stand for long periods of times, I feel shaky. I feel like I may faint, and when it comes to the inner ear can give you similar symptoms, right? But that's where you're going to say, are you dizzy seated? Are you dizzy with quick head movements? Are you dizzy walking? Or is it just with positional changes? And if we say, hey, it's really only going from lying to standing, there's two things we now have to rule out. We have to say, is this more BPPV or is this more vascular, right? And that's where we can look at vitals. So we look at blood pressure, both sides, line, heart rate, and then we look at it standing. And if there's any fluctuation in blood pressure or heart rate, we start to think, there may be more of a vascular component versus more of an inner ear, right? So that's kind of how we differentiate. But a lot of times the patients will describe it more as a faint lightheadedness versus a spinning or floating sensation.
Yeah. And then once you determine which it is, then your treatments are going to look vastly different, really.
Yeah,
So,
totally, 100%.
Yeah, dizziness is not always dizziness.
No, and like you said, I think the biggest thing is because patients will always just say dizziness, or they'll say vertigo, right? And really, vertigo is just true spinning. So a lot of people don't actually have vertigo. So you're gonna have to guide them and help them to say, describe your dizziness for me, and then you can help say, oh, so it's more of a dizziness like this. And a lot of times people will be like, yes, that's exactly makes sense. I just couldn't find the words for it, right? Because people with dizziness have the craziest descriptions. I've had patients where they're like, my left jaw is spinning, or my right forehead feels like that's really, really funky stuff. So you really have to help them kind of hone in their symptoms and what they're feeling so that you can better kind of differentiate, is it more vascular blood flow or is it more inner ear?
And then, yeah, exactly. And then to take it further kind of down the chain, we've talked about kind of central dizzinesses and peripheral dizzinesses. Can you talk at all about, maybe we talked about maps earlier also, can we talk at all about maybe like a cortical type of dizziness? Yeah.
Totally, definitely. So really, really cool area when you look at think of people have always thought of the brain as, right, this area does this and this area does this, and we're starting to realize that it's more about association areas. So it's like this conglomerate overlap of like 5 different cortical areas, right? So you have places like the anterior parietal lobe, the medial superior temporal lobe, the ventral right? You have all these different areas that have a lot to do with integrating inner ear, vision, and proprioception. So when you're looking at a lot of these cortical areas, they have more to do with taking the info in, collecting it, and then making sense of it. But not only making sense of it, attaching emotion with it, right? So when you look at things like the prefrontal cortex, certain parts of the prefrontal cortex take sensations of current body, right? But then they also say, last time I was in this situation, I was really dizzy. I feel dizzy. I am now anxious. So a perfect example is I had a patient who had really bad BPPV, and it was long gone. But every time she came back into the office, she would say, hey, Dr. Maynard, I've been feeling amazing, but you know what? I feel kind of dizzy. And every time I walk in this room, I feel really, really dizzy. Why is that? All of her stuff's fixed. She feels great outside. But you start seeing these learned behaviors and these cortical networks start to say, hey, I associate this room, these people, this environment with dizziness, right? Yeah. And this is where, a lot of people talk about PPPD or like postural perceptual dizziness, things like that, where you'll find a lot of patients, and this is where we tend to use a lot of like hypnosis and meditation. So where if everything from a standpoint like brainstem, cerebellum, everything looks good, but they still perceive this funky dizziness. That's where we use a lot of mindfulness to try to tap into some of those more cortical areas like the insula and stuff like that, and work on body awareness. Here's my arm, here's my leg, here's what my face feels like. Here, a lot more kind of like introceptive awareness work, because if you have a whole year of being dizzy, you could change the input, but you've made such a plastic connection that cortically you still perceive it. So it can be really hard to differentiate, and unfortunately those are the patients who get tossed aside a lot by medicine and get told they have anxiety, and they get put on psychiatric medication. So those type of patients, like I said, will use a lot of mindfulness meditation, but honestly I think that's where a lot of our functional therapies are working, right? So when we're doing, head turns with optokinetics, or balance drills with NSI and things like that, I think we're pushing a lot of these cortical networks to integrate information better. So I think all the therapies we do are having more of a cortical aspect to them, but I think that's where everything we say to a patient, the environment we put them in, their mental state is all so important, because so much of it is heavily perceptual.
Absolutely. And this whole topic has been dizziness, and I love that we take this simple topic, dizziness, which could mean one thing, a different thing to 100 different people, right?
Yeah.
But the same word. And then we've talked about, okay, so maybe your treatment approach is going to be more towards the neck causing the dizziness. Maybe, you're doing more interoception types of therapies. The therapies look so vastly different for this one thing, and it's really, really our job to find out what is causing this simple word, this dizziness, that so many people have different interpretations of.
Yeah, no, I couldn't agree more. And that's what's, I think, kind of cool is I think the more creative you are with this stuff, the more fun, and a lot of times the better results you'll get. Really, I think you really have to think outside the box when working with patients with dizziness and say, how can I link all of these different things in? How can I link gait training, foot training? I mean, we do a ton of work on building intrinsic foot stability, glute stability, single leg stability with a lot of these dizziness patients. A lot of people be like, why do you have that person doing a squat with a band? And then they stand up and they're like, oh my God, my dizziness is almost completely gone, because you understand the integration of proprioception or neck, right? So I agree. Some people may look and say, why are you doing that for their dizziness? But when you understand it, it's really, really cool and fascinating.
Yeah, absolutely. And then to tie in, you said earlier that you were interested in kind of the sports performance as well, right? So looking at the vestibular system and maybe dizziness, but the vestibular system as a whole, how have you seen maybe muscle imbalances or sports performance be affected by these various vestibular aspects?
Definitely. So actually, it's a funny story. And it was a little scary one. So I had a kid. I was working with his dad, and this kid is like a upcoming big time football player. He's going into high school, already getting recruited. And he's like, will you work on my son just from like a performance standpoint? I was like, sure. So we were doing some work, and I found some funky kind of imbalances. So I did some vestibular rehab. I did a few repositioning maneuvers, and the kid didn't really have symptoms. And he comes back to me the next week. He's like, I don't know what you did, but I couldn't throw the ball anymore. His throwing got completely messed off for a day or two, and it ended up coming back to normal. But he's like, I'm not sure what you did, but I kept throwing balls into the ground. I kept throwing them over receivers. He's like, I had like no control over my arm for 2 days. And it was like, wow, we didn't touch your arm. We didn't do anything with your arm. We did some stuff to your inner ear, and we changed your perception of where you were in space. And until you recalibrated that, your brain was kind of lost. And it was a cool example, because he ended up doing really a lot better. But it was also to see how powerful that not only can it do good, but it can also do harm, right? Because you're totally manipulating one's experience of reality, and then you're seeing something like throwing mechanics completely change like that. So that was one kind of really crazy, dramatic example of just doing vestibular rehab totally affecting someone's throwing mechanics.
And like you said, you're playing with something so foundational, or you're working with something so foundational, and it has so many downstream effects that you really have to be wary of. And then an interesting thing with this, I don't know if you want to get into maybe the whole astronaut studies that they were looking at with Cadet Kelly, who was up in space for a year, and then they did some research, or they I think looked at his vestibular system after. Are you familiar with the study and kind of the outcomes?
I don't know about the direct one. I've seen some of the astronaut studies where they've looked at all sorts of different things of like vasculature, bone density, like all sorts of what seems somewhat unrelated, and seen total changes with that lack of gravity. So it might be a different study, but I have seen some of it where you see all these other effects that seem unrelated just start to spiral out of control.
Yeah. The vestibular system is so key to so many things, and
it's pretty crazy. It's funny. So you're in this world, and I think all of us, right? We learn from so many different doctors, right? And they talk about these miracle cases, and right, you do this, you look that way, and oh my God, they can walk. And for the longest time, I was like, I don't see it. I don't get it at all. And then like I said, working a lot with Dr. Traster and going through his vestibular course and just focusing more, I started to see, wow, these what look like miracles really can happen on a daily basis when you start messing around with the inner ear. I had another patient the other day who her main symptom, she was a 2-year head injury, and she was doing well, but she had a lot of short-term memory and emotion. Anytime she would work out or do any physical activity, she would bawl crying for like an hour, and she couldn't stop herself. And she had a subtle little nystagmus, and we did a few different things, knocked it out, and I was kind of like, I don't know if this is really going to do anything. Let's just look and see. She came back in my office today, and she's like, it's all gone. She's like, I don't cry anymore with exercise. And I was like, I wasn't fully expecting that. You see crazy things when you start manipulating one's perception of gravity. And I'm surprised every day in the office with people when you fix inner ear things and they come back and they tell you things that you think are totally unrelated are completely fixed, and you're just kind of dumbfounded a little bit.
Yeah, absolutely. Would you say it's maybe one of the most foundational things that you do in the office, or one of the most impactful things that you do in the office?
100%. I'd say, at least for me, that is my foundation with most patients. And once again, I'm kind of biased now because I see a lot of dizziness patients, but even ones who aren't, if you don't know where you are in the world, how is anything else really going to work? It's like if you interacting with someone, speech, all these other things are prerequisites to understanding where you are first. So I start with that with every patient. And like I said, if it's not there, we don't touch it, we don't work on it. But more often than not, I'd say 90% of concussions or more have some sort of inner ear deficit.
Yeah. And I think you mentioned earlier, vestibular input is just a constant thing, right? So if there are these imbalances and we don't address this first, there's going to be a constant misinterpretation of environmental information. So all the other therapies that we might implement may not be as effective or as powerful as they should be.
Yeah, no, I couldn't agree. It's kind of like your base foundational map, and then off of that, right? Because if you're wanting to do NSI and do reactive or syncopal, right? So you're training a ton of where is the world in reference to me. What's the point in doing that if you don't even know where you are? Are you going to just further drive some inappropriate compensation that's there? Maybe, maybe not. So yeah, I think it's a really important foundational tool.
Absolutely. Well, Dr. Maynard, I think this has been a phenomenal talk. I think listeners and viewers are going to get a lot out of this today. We're almost out of time, but I want to give you this opportunity for any final thoughts to leave us with.
Yeah, no, definitely. I mean, I'd say one of the biggest things I see with patients with dizziness or inner ear disorders is don't lose hope. There's so many good people out there that can help. Your clinic is one of them. You guys have amazing doctors at your clinic that can help, and it's so sad to see the patients I've seen with 2 years of dizziness, 3 years of dizziness, a year of dizziness, and it wasn't anything crazy, right? They were just mistreated, misdiagnosed. So like I said, I think the biggest thing is if you have dizziness, vertigo, disorientation, brain fog, things like that, please find yourself some sort of chiropractic neurologist or functional neurologist who's trained in this, because you can make profound changes in
Mm-hmm.
most of these different conditions. So, I'm on a lot of different forums, and I see so many people on forums just saying, "Oh, I take this medication. I guess I just got to deal with my dizziness for like a year." And then you have another person chime in. They're like, "Yeah, it took 2 years for mine to go away." And it's like, it doesn't have to be that way. So
Yeah.
please, please, please find someone who's trained, and you'll most likely find relief a lot quicker. So like I said, there's tons of hope out there for patients with dizziness is probably the biggest thing I have to say.
Absolutely. That's perfect. Beautifully said. And then if these patients want to get in touch with you in your clinic, how would they do that?
Definitely. So like I said, our clinic is Integrated Health Systems, and we are located actually in Inglewood, Colorado, which is just kind of outside of Denver. You can contact me. My email is dr and then Maynard, Maynard, at integratedhealthdenver.com. So you can always email, or you can email at info@integratedhealthdenver.com. We usually always I like to sit down with patients, and if they're kind of curious about what we do, sit down for 30 minutes to an hour, no cost, and we just kind of chit chat about what they have going on and see, do we think we'd be a good fit? Do I think someone else would be a better fit for them? And it's just kind of a time to see, what kind of things we may do for them. So yeah, so like I said, you can shoot us an email or check out our website, integratedhealthsystems.com. So yeah.
Awesome. Thank you. Well, I'm hoping that more people are going to reach out now that they hear this. So,
Yeah, perfect. Like I said, thank you so much for hosting this. I think it's great to get this info out for individuals to learn. So,
of course. Well, it was my pleasure to host you today. Thank you for taking time out of your busy schedule. But yeah, this has been your host of the Neuro Wellness Podcast, Dr. Coppus. Be well.